Good afternoon, everyone. Thank you for joining us with the fourth clinical meeting for the month. And I would like to welcome you all for the meeting, as well as I would like to introduce our speaker, Dr. Pradeep Jayatilaka. He's the consultant physician in Bedford, Philadelphia, as we all know. And I think we can gather many clinical experience from him, as well as practical aspects of managing thyroid disorders. And I will especially thank Dr. Pradeep Jayatilaka for accepting this request in a short notice and been preparing this lecture in a short period of time. So without further ado, I would like to invite Dr. Pradeep Jayatilaka to conduct this lecture. And at the end of the lecture, you can ask the question if you have any.
Thank you, Dr. Dimantha, for your kind introduction, and welcome you all. Nice to see you again with another CME lecture today. And this is a very known topic, and we are most probably familiar with this one from your medical school. But there are a lot of things to learn in future with this topic actually. And my topic is actually the clinical pulse and pitfalls of thyroid dysfunction. And under this topic, I would like to some objectives to cover here. First thing is the bit of the things of physiology you might know well. And another thing is the common topics of presentations of thyroid diseases, hypothyroidism. Under that heading, I would like to discuss some primary, secondary hypothyroidism, subclinical hypothyroidism, and entities, extreme entity like mixed edema, coma. And another entity is thyrotoxicosis, hyperthyroidism, and subclinical hyperthyroidism, and another extreme entity, thyrotoxicosis crisis. And I would like to interpret thyroid function, how to interpret thyroid function test in clinical settings. I would like to discuss a bit of regarding that also. And other thing is the how to deal with the clinical settings with the thyroid profile and with the patient. Right. A little bit of physiology. As you know, thyroid is a marvelous gland, endocrine gland. Actually, it is very accessible to us. Most of the endocrine gland actually difficult to accessible. This one is very superficial. It has two actually lobes with the connecting with the isthmus, and there are another brother to endocrine organ behind him. And actually, thyroid plays a major role in our metabolism and all human activities in the body. And usually, the thyroid gland produce mainly the main substance is the T4, is a thyroxine hormone. Usually, there are two types, mainly the T4 and T3. Usually, these are produced by the follicular cells. Usually, T4 mainly produced by the thyroid gland, but out of that, T3 is very small proportion, usually delivered from the thyroid gland per se, and rest of the T3 is converted through T4 in the bloodstream. That is the most active form which act on the cellular level. And there are other products from the thyroid glands, usually follicular cells. There are three main cells actually. It's a three component, mainly the follicular cells, colloid, and parafollicular cells in the thyroid gland. Usually that is the anatomy. Usually follicular cells will also produce thyroglobulin, that is a protein. Another thing is another hormone will produce from the parafollicular cells, that is called C cells. It secrete calcitonin, that is another hormone actually. And regarding thyroid hormone, basically we focus on active form here because it acts on all the cells in the body actually. Usually it, from the beginning in the neonatal life, in the embryo also, it will help to develop our brain, to maintain our somatic tissue development also. And it also affecting whole cells through nuclear receptors, act on basically all the metabolisms, usually protein, carbohydrate, and fat metabolism. Without thyroxine hormone, we can't behave like a human actually. Not even human, even the animals also. And right, I told you that is another hormone, calcitonin. We are not much talking about this one, but it will release from the parafollicular cells in response to the hypercalcemia. blood calcium level. And these hormones mainly are transported by the three main proteins. Basically, the first thing is the TBG, thyroxine globulin, that is the major component, and other thing is the transthyretin and albumin. But the major part is done by the thyroid binding globulin. And as you know from the medical school, this is the common diagram. This is the HPT thyroid axis, actually hypothalamus pituitary axis. This is the simple things happening in the body. Usually the hypothalamus will release thyroid releasing hormone. It will act on the anterior pituitary, and he will release thyroid stimulating hormone which act on thyroid, and ultimately they will produce, as you know, whole T4, and nearly 30% of 3 from the thyroid gland, and it will go to the bloodstream and convert into T3, and that is the active form which act on the cellular level in the through nuclear receptor. Right. Then I will discuss what are the entities with this disease entities with this common organ. And that is the commonest presentation we are encountering in the clinical settings, hypothyroidism. This is actual, as you with the name, this is the low thyroid hormone level in the body. Actually, it can happen in congenital form or acquired form. Another thing is, according to the site, it could be due to primary. Primary means completely from thyroid gland, and secondary means it should be from the pituitary or hypothalamus. If it affects thyroid and hypothalamus, we'll call it secondary hypothyroidism. And the thing is, even the simple this thyroxine hormone is not adequate, but the presentation might very huge spectrum is there without non-specific symptoms to extreme entity like myxedema coma, thyrotoxic crisis. Usually the myxedema is the lowest entity in the hypothyroidism. And the thing is, if there's no adequate thyroxine hormone for a long time in the body, it might cause significant mortality and morbidity. And this is the important slide actually, because all the things are here. Because I told you earlier, this is a low thyroxine level can affect all the body, not only the single cell or single organ. In that case, usually CNS presentation from head to toe, I would like to introduce. Just CNS usually they might present it just sleepiness, lethargy, and with some cerebral ataxia to depression. There's a huge spectrum is there actually, and usually renal involvement it affect actually renally through reducing water excretion. They might present like edema and hyponatremia. And usually reproductive system, usually it affects male and female both, but more prominent in the female side, and with the ovulation failure and menorrhagia and a lot of menstrual irregularity. Male side, it might present with erectile dysfunction, not even male, females also might cause. And other things we are seen commonly in the medical boards, usually a lot of lipid abnormalities might cause with this hormone inadequacy. Usually the high triglyceride level in the lipid profile and HDL level. And if you talk about the metabolism, it can cause low metabolic rate and cold intolerance. This is not a good time. Actually, you might sleep with those things because you are more familiar with those things, right? And if you see in the hypothyroidism with the skin involvement, it might cause some lot of hair changes, skin thickening, and very dry skin. And myxedema means usually it's a puffy appearance in the patient. And it can affect cardiovascular system. It can cause a lot of changes, usually bradyarrhythmias and pericardial collections, and some cardiac tamponade effect sometimes with the end stages. And growth wise, it can cause some weight gain, GI system weight gain, and constipation may be a presentation. And musculoskeletal system, this is a very non-specific symptoms, might present with muscle pain, stiffness, and sometimes significantly the proximal muscle involvement with proximal myopathy. This is very important slide. Actually, you can keep this in mind, because then you can order in future with the thyroid function if you're suspecting patient with these symptoms. And right. And when you are talking about the hypothyroidism etiology, many era ago actually, iodine deficiency was the commonest one. Nowadays it has changed. Now they are telling that autoimmune thyroiditis is the commonest cause for hypothyroidism, but still congenital part is still there, and other things may be iatrogenic causes like drug-induced lithium and amiodarone, and following thyroidectomy and radioiodine also can cause persistent long-term hypothyroidism. And these are the causes for primary. And secondary, usually I told earlier, with the pituitary illness and hypothalamus illness can cause secondary hypothyroidism. Usually severe illness also can affect straight away to the hypothalamus and pituitary per se. They might present with the different presentation, right? This is the common diagram, as you know all. The hallmark of the hypothyroidism, biochemically, they will present like high TSH. This is a wide range of spectrum. And the other thing is the free T3 and free T4 also both are low. That is the usual common scenario. And then the thing is reason for, because thyroid is not producing, and usually the T4 and T3 is the negative feedback for pituitary and hypothalamus. In that case, if T3 and T4 is not there in the primary thyroid gland itself, it can cause increased TSH and thyroid releasing hormone. Both can increase due to absence of negative feedback, right? And even though many years gone with this illness, the management hasn't changed, because still we are using levothyroxine, that is T4, because even though the severity of gland dysfunction might not decide the dose, most probably, because most probably they have given the dose range to start from 1.6 to 1.8 microgram per kg per day, because with the value we might not decide the dose, most probably. In that case, you might start with the according to this dose range. And other thing is we are not giving T3 because we know that is the active component, but we are not giving T3 because difficult to manage with T3, because it will very active form. The levels, blood levels will go very quickly. We can use T4 very safely. T3 we can't use like that because it's short half-life and very active form. The blood levels will go sky high quickly. Be difficult to monitor. That's why we are using T4. And we have to take in empty stomach, even though we have learned from medical school to take as early morning. It can take actually, if you can keep meals apart, usually 30 to 60 minutes apart, you can take any time. But most of the time we are used to take in the morning, because we can maintain that fasting period. And usually T4 has long T half, more than 7 days to get adequate blood level, but it is not, that's even that level also we are not checking, because it will take long time to normalize the TSH and blood levels of T4. Usually half-life is, they are telling 7 days, but it will take more than that. And in that case, steady blood level will appear after 1 month actually, T4. If we started T4 now, but we have to take regularly, it will, blood level, it will normalize within nearly 1 month. And usually, I told you earlier, we can start with this dose, each and every patient, but only one thing is, elderly and is having significant ischemic heart disease, we can't start that dose. We have to start very low dose, and we have to go for very slowly, because there are a lot of action on cardiovascular system with the thyroid. Another thing is, as you know, this when we are taking this thyroxine, we are not taking only the thyroxine, we are taking a lot of things. Usually the elderly patient with the polypharmacy, we are giving a lot of medication with them. These are the main counteractive medication, usually iron preparation, calcium and magnesium. Those definitely affect the thyroxine absorption. In that case, if we are given adequate dose, we are each clinic visit we are increasing the dose, but we can't expect that much of normal TSH. That is the most reason, because they are taking other medication with that one, it will prevent the absorption. And usually when we are monitoring TSH, usually I'm talking basically the primary hypothyroidism here, we have to check TSH after starting T4. Nearly we have to wait 6 months to 2 months, 6 weeks to 8 weeks. Before that, we can't assess their steady level in the blood. And usually we have to increase the thyroxine dose, levothyroxine, to keep TSH this range 0.4 to 4. And usually when we are giving thyroxine, better not to do for the follow-up, no need to check pre-T4 and T3, because our target is to maintain the TSH in the primary hypothyroidism. In that case, we can check with the T4. Even with the long-term thyroxine treatment, if your blood levels are steady, no need to check frequently. No need to check like 3 monthly, 6 monthly. You can wait annually. I have seen a lot of in the clinic visit, we are doing every 3rd month, 6 months like TSH. We are burden on the patient and we are burden on the health sector even. If levels are steady and we are giving regular dose, if there's no recent dose adjustment, no need to do that much frequently. We can go for once a year. But sometimes we need to go for some close monitoring in this group of people, usually the pregnancy, children and adolescents in growing age. And if we are having some significant weight changes without any other illness, some bariatric surgery or something, you might need to go for some close monitoring. Right. Pregnancy, anyway, it's very important to monitor closely, because there are a lot of reasons I will tell you later. Right. The thing is, this is the entity we have seen most of the time in our clinical practice. If we are given adequate dose of adequate period levothyroxine, but we can't see adequate suppression of TSH. It's almost most of the time TSH levels sometimes may be elevated, and we argue with the patient most probably why you are not taking treatment, because we are not telling the patient. And there are a lot of reasons to suppress the TSH, but one thing is the poor compliance, obviously. Another thing is the some drug storage quality. Sometimes we have seen that bottle may be some bit of dark bottle. No? Usually they are giving thyroxine. Maybe some sunlight exposure might disrupt the usual activity. Another commonest cause is the malabsorption. It can be due to primary or like iatrogenic, like with the polypharmacy. Another thing is the drug interference. I will discuss usually amiodarone, and lithium also might cause some. You have to check that drug list also when we are facing this issue. Another thing is the assay interference. That is also happening in Sri Lanka, because some quality control and other lab issue also we have encountered usually in the clinical practice. We can't find a solution for that. And from our side, what we can do, we'll see. If you can't see any adequate suppression of the TSH, even we are giving higher dose of T4, next option would be the thyroid absorption test. Usually we are not doing here, because this should be done under some supervision, because the thing is, I have seen some in the endocrine people, they are doing this one, because we have to go for loading dose of T4 usually, because to assess how the absorption. Usually with these refractory cases with the persistent high TSH, we can perform this thyroid absorption test. Usually when you are giving loading dose, means 10 milligram per kg, 10 microgram per kg like dose, and usually for the fasting patients, and they will collect some repetitive sample in this hours gap, usually 0, 2, 3 and 6 hours gap, and we have to accept this much of rise. Usually they are expecting more than 0.4 nanogram per deciliter. That is the usual pattern of rise of blood level of T4, pre-T4. If it's not happening actually, that is the reason for absorption failure actually. Other thing is, we can exclude the poor adherence also with this test. Usually we are not doing commonly that one. But if we're really worried about his compliance and other things and absorption, we have excluded all the things. we can go into this test under the supervision with the board admission. And this is a commonest entity what I feel we are encountering the usually clinical settings, subclinical hypothyroidism. Main reason most probably, most of the time, if you are thinking hypothyroidism, we are ordering only the TSH, because with one thing is the financial factors, other thing is we are inherited, because we are from the medical school, we are learning to monitor with the TSH for the primary hypothyroidism. That is one thing. But I would prefer, if you are suspecting hypothyroidism, better to couple with pre-T4 for the first diagnosis. Then straight away you can come to a diagnosis. No need to repeat again in 3 months, 2 months of time. If you can order TSH with pre-T4s straight away same time, then you can come to this diagnosis. Usually the subclinical hypothyroidism means they should have high TSH with normal pre-T4. TSH, the range might be vary. It could be up to even 10, usually more than 10. That is the indication for treatment according to our guideline. But below that, with the normal pre-T4, even we are taking that is subclinical hypothyroidism. Then you can decide your treatment plan. And usually the subclinical hypothyroidism patient, we know the subclinical means there's no obvious clinical symptoms, but they might have very subtle some symptoms. We have to dig into that one with the history, and sometimes some examination, some investigation might support for that one. Thing is, if you neglected this subclinical hypothyroidism for some patient categories, they might go into overt hypothyroidism in long run. And usually these are the commonest group. Usually autoimmune thyroiditis associated with TPO antibody, thyroperoxidase antibody. If that is one thing, we are also not doing that much commonly. If you are suspecting, usually the females, if he's having subclinical hypothyroidism and she's in his reproductive age, sometimes we might need to do thyroid peroxidase hormone antibodies. Then we can early pick up who are going to overt hypothyroidism in future. Because if this antibody is positive, they are more prone to get in future. And other patients who was on radioactive iodine also might cause long-term hypothyroidism. And usually, what we practice usually, if TSH more than 10, straight away we are more prone to start thyroxine treatment. If less than 10, usually I also prefer to start without much bothering. If the TSH around 7 to 10, like, most probably I would start thyroxine treatment. But some patients, if below 7 or 6, but still in hypothyroid range, usually 4 to 10, you can consider treatment this sort of patient groups, usually children. We can start, and other patients with TPO antibody positive ones, you can consider even they are subclinical group. Another thing is pregnancy, we have to consider actually, because there are a lot of reasons I will discuss. And who is anyone who planning for pregnancy and who are still labeled as subfertile, they would have ideal for this treatment option. And if you couldn't find any reason to start, but if you are thinking it might benefit for this patient, better to write in your clinic book, you are starting this treatment as a clinical trial. In that case, with that explanation, you can start, but you have to monitor this patient. Better to start with very lowest possible dose, and you have to monitor. And the other thing is the dyslipidemia. If patient present with dyslipidemia with the bit of unusual lipid profile, you might consider even with this range, we can go for T4 treatment. If you are not going to treat, if you are not decided to start treatment at the moment, you have to monitor this patient. You have to go for another follow-up TSH in 6 months time. The thing is, as I told earlier, some TPO positive patient, they might go into overt hypothyroidism, usually almost all patients, but others also can cause, usually 5%, they might go into hypothyroidism in the lifetime. This is the secondary hypothyroidism, that is hypothalamus is pituitary, both are not working sometimes either. And that is the usual clinical biochemical picture. They will present with low T3, T4 with normal or low TSH. Sometimes TSH may be normal, but actually T3, T4 may be low. In that case, if you are not coupled with pre T3 or T4, you might not pick up these patients also. Right. And these are the usually commonest causes. It was in the previous diagram. Other important thing is if some secondary hypothyroidism patient, they will present not only the low TS thyroxine issue, they might have other hormonal issue also. That is another thing. Usually they might present with other anterior pituitary hormone involvement, FSH, LH, and ACTH deficiency also. And even though this is secondary or pituitary hypothyroidism involvement, treatment is same. In that case, we might start levothyroxine in this patient. But the thing is, when we are monitoring this patient, we are not going to do TSH because this patient TSH anyway low and T may be normal. In that case, we have to monitor with the free T4 levels. And other treatment target is actually we have to maintain upper limit of free T4 because we need to keep his cells very active. In that case, we have to go for free T4 upper limit, not the lower half. When we are monitoring primary hypothyroidism, TSH better to keep in that middle range usually. And other thing is sometimes when we are replacing thyroxine some patient, that is very not a common one, but it is very life-threatening condition. When we are without replacing some ACTH deficient, can you imagine if you are having some adenosine issue, if he's having low cortisol level with the ACTH involvement, and if you given thyroxine to increase his metabolism, suddenly he might go into adrenal crisis. In that case, we have to think for what we are going to start treatment thyroxine, whether primary or secondary. Sometimes you might stuck in some trap. Sometimes you can't differentiate what has happened to the patient. You are going to do some better thing for the patient, but ultimately you might precipitate the dysfunction crisis. And this is another entity of thyroid disease. You sleep, most of the time. This all the hungry birds, no, right? I will rush through quickly. Actually, this is a thyrotoxicosis. This is the whole biochemical picture with the low TSH and high pre-T3 and T4 levels. No need to do both actually, just only one thing. Sometimes there's one entity, usually the isolated T3 toxicosis you might miss if you haven't do two tests, pre-T3 and T3 both, if you're suspecting some patient with hyperthyroidism. In that case, you have to better to do in the first visit, better to do the 3 tests. Right. This is the commonest causes for thyrotoxicosis. Commonest is the Graves nowadays, but there are a lot of other causes, solitary nodule functioning and toxic multinodular goiter also there with the single active toxic nodule, and other things are thyroiditis. Usually most of the thyroiditis cases, they might present to the early phase with the hyperthyroidism due to a sudden destruction of the thyroid gland. It will release a lot of stored T4. That is the reason. Another thing is some ectopic thyroid tissues, usually in the ovaries. These are not much common actually. Another thing is the pituitary issue with the thyroid TSH secreting tumors. And these are the common clinical symptoms you might have seen in the hyperthyroidism patient. Usually common things are unintentional weight loss and heat intolerance, palpitation, sweating, nervousness, and a lot of tremors and GI upset. These are common symptoms actually you might be aware. And physical signs, usually each and every patient might not show physical signs, but tachycardia is a common thing and tremor might be there. And usually Graves' disease might present very specific some eye signs. You might aware this one. There are a few signs are there, maybe due to infiltrative or active thyroid tissue. And other lot of non-specific musculoskeletal pain, sometimes proximal muscle wasting, myopathy, and a lot of things are there, and other common skin manifestation. Even Graves' disease also can cause some specific skin manifestation. You might have gone through these things several times, but I want to brush up your memory, right? This is commonest, I told you, that is a Graves' disease, cause for hyperthyroidism. But we are bit of that diagnosis we are not giving most of the time. No, we diagnose patient with hyperthyroidism, but most of the time we are not giving proper diagnosis, whether it's a Graves or multinodular goiter with toxic changes. Most probably this clinical signs might help to give a proper clinical diagnosis. Usually the first picture will show a lot of things in these Graves related manifestations, and this is the usual severe hypothyroidism with the staring face, and he's having exophthalmos, and he's having some bagging of the lower eyelid, and he's having lid retraction. Lid retraction means the upper eyelid, and there's a iris, there's a obvious appearance, there's a gap, huge gap, but usual people we can't see that one. Another thing is they might have some external ophthalmoplegia, usually with the infiltrative disease. And there's another infiltrative pathology, usually is the skin involvement. According to the name, you might think it might have been seen in the hypothyroidism, but it is we can see in the hyperthyroidism, that is myxedema, pretibial myxedema, usually anterior shin. And other thing is the thyroid ectopathy, that is also more towards, if you're having those things, we have to label as the Graves' disease. Graves' disease, this is actually autoimmune basis, because this is a stimulatory antibody, thyroid receptor antibody, TSH, act on the thyroid to release. Then it can cause to stimulate thyroid gland, because this is a TSH receptor antibody. It will release a lot of thyroxine into the body, and but we are also not checking this one because it may be costly, one thing. But if you can do this one, that we can diagnose Graves' disease. Another thing, sometimes may have some subclinical picture of Graves' disease, usually in the pregnancy. If you can do this test, you might pick up earlier, because some neonate might get thyrotoxicosis crisis when they deliver, if you haven't missed earlier. Because mother may be very subtle changes, but if you diagnose with the trap antibody, it might cause cross the placenta, will act on the neonate. And nowadays they are talking about thyroid stimulating immunoglobulin, because now they are not checking most probably the trap. It also immunoglobulin, but they label as thyroid stimulating immunoglobulin instead of trap. And other two products are usually serum thyroglobulin. Right. This test actually we can. This is a hormone. This is a protein actually. This is from the thyroid gland follicular cells. But we'll monitor this one to check whether it's factitious or obviously from the thyroid disease, because we can differentiate from the serum thyroglobulin test. That is a protein actually. Other thing, usually if a patient is, if you're thinking it's a patient is toxic, there's another investigation we can do, radioiodine scan test, because we are not doing this for the hypothyroidism actually. If we are doing this radioiodine scan to detect the hyperthyroidism cases, what are the, identify the differential diagnosis, because there are, according to the uptake and level of uptake might decide our diagnosis. And treatment, sometimes the radioactive iodine we are giving as a treatment, usually that is different, that is I3-131. This is for the radioiodine scan. Iodine treatment usually depend on the uptake levels. If it's having high uptake, usually we decide that with that one we can decide the I3-1 dose actually. And we can differentiate Graves' disease and diffuse changes, whether it's a nodular one. Those things we can diagnose with the radioactive iodine scan. As I said earlier, with this uptake pattern, we can diagnose the clinical condition. Usually Graves, there's a diffuse uptake, and there may be some single nodule uptake is different. Another thing is the thyroid hormone resistant. There may be high uptake because TSH is always stimulating thyroid. In that case, the uptake may be high. Then other thing is the low uptake. Usually, mostly we can see in the thyrotoxic patient with thyroiditis and iatrogenic thyrotoxicosis. Their uptake is anyway low because they are suppressing the thyroid gland. And here, destruction is there with the thyroiditis. In that case, tissue is not there to uptake. Sometimes we are not doing these things commonly, but if you go for the detailed diagnosis, we might need these investigations. As you said earlier, this is management hasn't changed. This even with the hypothyroidism for the last few decades, because we have two options. Anti-thyroid drugs, usually these are common group actually. They both usually there are methimazole, carbimazole. This is the same group, like, and PTU also another same action, because they both are blocked the thyroid peroxidase enzyme. Right. The thing is, difference is usually we are giving carbimazole, not the methimazole. We are not practicing that much. Carbimazole is the commonest drug we are using. That is a pro-drug because methimazole is the active form of carbimazole. Usually, only few conditions we are using this one. PTU usually this is the act on thyroid gland, but PTU usually act on the peripheral also. It will prevent conversion of free T4 to T3. That is, in that case, effects may be very quicker than carbimazole. Usually, that's why we are using in the thyrotoxic crisis. And other drug we always try to couple with this one to beta blockers. Beta blockers actually they might work in two aspects. Mainly the it act on the adrenergic stimulation of the thyroid hormone in the tissue. It cut down that defect. And other thing is that they will cut down some peripheral conversion also, as PTU has done. And other entity, usually we are starting some calcium channel blockers, some patient, because there are some contraindication to start beta blockers. But the thing is, usually calcium channel blocker might not blind that adrenergic part whole body, because it might act on the SA node and it will reduce the heart rate only. That other part will not disappear most of the time. Right. Anti-thyroid drugs, they are the benefit actually, because we can go for this remission with this drug, and they might go for, because there are another two options actually. There's a surgery and radioactive iodine. Usually they might not need to take T4 for a long time if you are managing with carbimazole, and they might avoid surgery and they might avoid radioactivity. Some patients are there, some criteria are there. Each and every patient, we can't go for three options, all the three options. And risk is usually these, most of the things are dose dependent, and they might cause some cytopenias, usually the WBC mainly, and hepatotoxicity. It might maybe elevated liver enzyme or cholestasis pattern. And commonest are skin manifestations like rashes, pruritus, and those things, and GI upsets, and some drug-induced lupus. Out of those, usually the skin manifestation are the earliest presentation of carbimazole usually, because when we're starting treatment, we have to advise the patient what are the first thing you can notice, but other things might take nearly 3 months to appear some side effects. Little bit about anti-thyroid medication, carbimazole and methimazole. Usually we are using carbimazole. Usually we are giving daily dose, but we can divide according to, if we are going for the high doses, usually more than 20 BD. That is the maximum actually. I have seen some patients are giving 60, but I don't think that might, because it is there are a lot of dose dependent side effects are there in the future. In that case, maximally better to go for 40 daily, but it can divide it into 20 BD. Their half-life also usually 6 to 8 hours, maximum 10 hours. That's why we are giving twice daily. And usually carbimazole, what we learn from our medical school to postgraduate, the first phase of pregnancy, first trimester, usually carbimazole can cause some issue with the pregnancy, with the embryo. In that case, they were more preferred to change into the PTU in the first trimester. But nowadays, yesterday also I discussed with the gynecologist. He's telling that now that practice has changed. Now they are thinking that this side effect is minimum if patient in very possible lowest dose. If he's tolerating well with that dose and he's clinically euthyroid at that time, but she's getting lowest dose, most probably less than 10, most probably, they might continue even carbimazole in the first trimester. The thing is, their risk profile is same, uh, but sometimes PTU might toxic than carbimazole sometimes because they might affect liver and bone marrow than we expect than carbimazole. Right. Sorry. Usually, PTU we haven't much given this drug nowadays, but sometimes when we are giving this drug, we have to go for some dose conversion actually, because patient was on carbimazole, we can't start same dose. We have to go for bigger dose because this conversion is 1 to 10. Usually 10 times higher dose we have to go for PTU, right? And we have to go for divided doses also. Oh, I don't know, you are sleeping. Right, right. Okay. I just telling those things because you can refer those things later. Right. Other thing is, right. Right. As you said, I told earlier because when we are prescribing thyroxine, we not much concerned about his TSH value actually. They have given some dose range according to body weight, 1.6 to 1.8, but hyperthyroidism, it is bit different because there's some side effect dose dependent. In that case, according to the patient toxic state and level, you might decide the dose from the beginning. And in that case, we might start sometimes slowly because I have a lot of experience. I have started because bigger dose according to the TSH value. We have seen a lot of times more than 0.1 or something. Then we start with 10 or 15. 10. Usually they might present with a lot of GI side effect and some skin manifestation earlier. In that case, it's okay, better to start slowly. Right. Then you can gradually, you can increase that and better not to go for more than 10 anyway for the first visit. And usually before starting, we have to go for some full blood count, basic screening and liver function test. Because liver function test, usually, there are different. Usually carbimazole and that one, what is the PTU, they are manifestation different in liver derangement. Usually PTU for some deranged ASTLT most of the time. But carbimazole will cause cholestatic pattern. In that case, we have to keep eye on which drug is on and what we are going to monitor. And usually these are the contraindication. Usually neutropenia significant less than 1000 and transaminases above 5 times from the upper limit. Will not start most of the time. We have to think other reason for that one. And we have to educate patient even first day when we are going to start. That is also lacking from our side. Most of time we are not going to advise them, right? Right. Other thing is, as I told earlier, usually these two, PTU and carbimazole, both act on same mechanism. In that case, if once one was on carbimazole, if he's having this side effect, if you have changed into PTU, expecting a good response, but it won't happen because there's no interchangeable because both side effects are same range, same thing is happening. In that case, you have to go for another option, radioactive adenosurgery. This is just a rough the common complications. As I told earlier, this is the GI side effect is the commonest one. Is earlier it will appear first, but others some nearly more than 3 months later. Right. A little bit of beta blockers. Right. As already I have told you, because it will affect on mainly the blunting adrenergic effect. All are sleeping. Right. Calcium channel blockers is different. They will not act on adrenergic blunting. Right. And this is another clinical dilemma when to start treatment for subclinical hyperthyroidism. We have seen a lot of cases actually because hyperthyroidism means subclinical means they are clinically might not apparent. Pre T4, pre T3 might not completely normal, but their TSH value below the cutoff. Usually, for the better treatment decision, we have divided into two groups, the mild and severe. Usually, TSH less than 0.1, we'll take it like grade 2 severe subclinical, and grade 1 mild, it is between 0.1 and 0.4. This sort of patient, when we are treating, we have to think twice, because usually the age is, they are giving some criteria actually. If age is less than 65 with this range, mild range, you might not start treatment. But patient is obviously 0.0, less than 0.0, and age is more than 65. With this risk, usually possibility of bone loss and osteoporosis obviously, and if he's having some heart disease, usually arrhythmias, tachyarrhythmias, heart failure, may be related to thyroid dysfunction. And other patients with having some symptoms with not be difficult to grant it as a typical hyperthyroidism patients, but if you are in doubt with this unexplained weight loss, tremors, and said it can happen in any conditions, no? But the TSH level is less than 0.0, you might consider this starting treatment, but better to start very lowest dose, right? That is the criteria to start carbimazole. And this is just to summarize the Graves management plan. Graves disease usually hyperthyroidism. We are thinking we might need to go for lifelong carbimazole. Usually from medical school we learn around maximum 2 years. That is for the actually Graves, not the other condition. Sometimes Graves usually we can go for maximum carbimazole 12 to 18 months. Then you have to check TRAP antibody. If it's now disappear from the blood, you might think that is settling. Actually, that is relapse, and you can wait and see. But some patient, even after this duration, they might appear again TRAP antibody. If it's still there you have two options. One thing is you can restart again this TPO, thyroid peroxidase blocking agent with carbimazole. Another thing is you can go for another trial 12 to 18 months, and otherwise you can straight away go for iodine 131 treatment or surgery. This is 2025. Actually, there are not much difference to me, but they have changed what type of antibody they are checking. This is thyroid stimulating immunoglobulin, and here the difference is usually they will rely on carbimazole lifelong. This sort of patient, they will sometimes not go into surgery or iodine 131. They might go for lifelong carbimazole. It is very hard to model lifelong carbimazole. They might get a lot of side effects, but some patients, if they are not choosing these two options, they might go into the long-term carbimazole. As I said earlier, there are two options, surgical and radio 131, right? These are just for the reference. What are the pros and cons? What are the right? I will skip this one, right? This is actually what I shown. This one, many decades ago, most of the time, hyperthyroidism, they were radioactive iodine or operated. But with the time, it has changed the trend. Nowadays, they are more relying on the thyroid, antithyroid, usually the carbimazole. They are lacking going behind surgery or radioactive iodine. That is the trend I want to show you here. Nothing much, right? And this is the summarize to thyroid disorders and interpretation. You can leisurely, I already discussed most of the things. You can go leisurely this chart, right? These are some supportive tests when we are evaluating for thyroid disease. Usually we are not doing much, but as I told previously, this TPO antibody, if we can do that one, we can pick up earlier who are going to future significant hypothyroidism complications and hypothyroidism, and you can give some diagnosis on top of based on that. And this is another supportive test and thyroglobulin antibody test. We are not much doing, but might help to differentiate some cancer patient. I will tell that. And serum thyroglobulin, this is protein actually secreted from the thyroid follicular cell. Usually, it is a marker of differentiated thyroid carcinoma. Differentiated means papillary and follicular. There are three groups mainly, and the other thing is the undifferentiated, like anaplastic carcinoma, and other thing is the medullary. Usually, differentiated thyroid carcinoma will secrete serum thyroglobulin. In that case, we can use this test for the diagnosis, but most of the time we use for the monitoring purpose after radioactive iodine or surgery, with the thyroid tissue still there or not. If the issue was this antibody, I told you earlier, thyroglobulin antibody, if antibody is also positive, it is a supportive marker for thyroiditis, but if it is positive, that thyroglobulin levels might not give a direct clue whether that malignancy is recurring, because it might values may be false. If antibody is also there, that thyroglobulin value may be not supportive for monitoring. Right. Other test is ultrasound. We always hypothyroidism patient and even thyroid overactive thyroid, we are more tend to go for scan, no, each and every patient. But I couldn't find any hard and fast demarcation rules. Which patient we are going to do scan. Actually, obviously, if you can go for thyroid scan, if you're having obvious visible thing in the thyroid, that is first thing. Usually, whether you are suspecting nodule is obvious, goiter is there, you can go for scan. That is better. And other patients, sometimes we might not see anything. In that case, there's sometimes you can't, no need to go for each and every patient. But if you're suspecting some family history, if thyroid cancer, usually there are association with some medullary carcinoma from the background of family history, some endocrine diseases. In that case, you might need to go for thyroid scan, this sort of patient. And actually, thyroid scan is very helpful because we can differentiate some lot of diseases. Usually, Graves is active thyroid, usually is a hypervascularity. We can detect from the thyroid, and some nodules we can evaluate with the scan, and according to the texture we might give some whether it's thyroiditis. You have seen a lot of that reports, no? How they are telling that this is thyroiditis, or they have given the diagnosis without FNAC because according to the texture. Another thing is if you are having thyroid nodule more than 1 millimeter, if his patient is not toxic, you can have to go for the FNAC. If you have toxic, you can go back to the radioactive iodine. If it's clinically toxic, you can go back to the, if it's less, if it's not toxic or hypothyroidism, you might go for, with the nodule, you can go for the FNAC. Right. That is other thing. This is also very clinically relevant slide actually. We are doing a lot of thyroid function test unintentionally, what I feel, because better to think what we are going to expect this patient doing thyroid function test. There's no screening such test, but some colleges, they are telling that more than 60 years annually thyroid function test might help to pick up, because anyway, as you know, with the getting age, all the organs getting function getting reduced. In that case, as the thyroid also it can cause, it is that is the reason usually the elderly patient might present with hypothyroidism with a lot of non-specific symptoms. This sort of patient, better to go for some screening with the thyroid function test, but better to couple with, if you are thinking clinically hypothyroidism, better to go for 3 tests. If you are thinking hypo, better to go for even 2 tests with the free T4 and TSH. Usually, if we sign background history of autoimmune condition, and nowadays even cardiology guideline also they have included TSH for the metabolic syndrome screening as a TSH1 component. And past history of neck irradiation and goiter obviously is there. If children developmental delay, and usually female, that group most probably we are doing the screening. Usually the menstrual irregularity and a lot of non-specific symptoms. And if he's having pituitary disease, anyway we have to go for. And other group is usually this patient has been on amiodarone, lithium, and some checkpoint immunotherapy inhibitors. Usually we have to go for thyroid screening. And there's a under the PO evaluation, we might need to do TSH in clinical setting, because we had one case actually when we were doing register period. We did all the investigation, this patient, because he's PO, he's getting the small PO spike, even daytime, nighttime. But only small clue was there was some hypercalcemia, because now we are about to go for CAP. But suddenly one register has ordered thyroid function unintentionally, but it came as obvious hyperthyroidism. Ultimately, that may be the reason. We couldn't identify any suspicious things from the examination history and anything, but low-grade fever with slightly high calcium. Ultimately, we diagnosed this patient PO is hyperthyroidism. Right. And these are some blood investigations you might deviate to go for thyroid function assessment. Usually, we have seen myriads of cases of hyponatremia in the board. That is one presentation, as I told earlier, because the kidney involvement with the poor water excretion might cause hyponatremia. Hypercalcemia usually associated with the hyperthyroidism. And osteoporosis, we have seen a lot of cases in the elderly, better to do TSH if it's having obvious cytopenia. Osteopenia. And cytopenia, usually it can happen even hemoglobin. You have seen a lot of anemia patient. We might order thyroid function test. Usually hypothyroidism can cause anemia, low HB. Hyperthyroidism might cause low platelet sometimes. You might miss, we couldn't find some reason for this patient. Sometimes if we haven't think of this entity also. Another thing is the liver enzyme derangement, and sometimes CPK, high CPK, alkaline phosphatase, and deranged liver enzymes. Always not the fatty liver sometimes, because when we ask for the scan, they will write fatty liver, but low TSH may be the reason. Sometimes thyroxine, right? Another thing is the dyslipidemia. Usually, if you have seen very deranged lipid profile, unusual patient, usually the dyslipidemia, their commonest presentation, they are telling high triglyceride, sky high triglyceride with the derangement of LDL. Actually, LDL also can cause issue. Was if it's coupled with high triglyceride, we might see LDH may be normal or low. But both components can be high with the low underactivity of the thyroid gland. Another thing is the neurological manifestation. There are a lot of cases with dementia under pathway, dementia evaluation pathway. We are doing thyroid function and polyneuropathy evaluation. Those are the common entities usually present to the elderly population in our medical wards. And arrhythmia, usually tachyarrhythmia, bradyarrhythmia, whatever, we have to go for some thyroid assessment. Oh, we'll finish though. What we can do? Is it okay to continue, right? These are some clinical, common clinical settings we need associated with thyroid dysfunction, right? This is also another pitfall we are doing. This is sick euthyroid syndrome. We are not diagnosing this one. We are labeling always patient with the thyroid disease. Sick euthyroid means the patient is sick, then your thyroid is sick. In that case, test might be very varied. Usually, a lot of patients with some significant clinical illness, their thyroid is underactivity. In that case, they are free T3 and T4 anyway low. It is not due to per se thyroid disease, but any other disease, even infection, whatever. And their TSH may be normal, low, because in that case, you might trapped again, no? Because why you ordered TSH this patient? If you are not thinking if he's having obvious thyroid disease, there's a provision to start. You can do thyroid function, otherwise we'll wait. The thing is, you can get some supportive evidence. This is where the euthyroid, or this is a thyroid issue per se, or sick euthyroid. You can couple with reverse T3, but we are not doing much. But cortisol we can do. If he's having any other illness, if his adrenal gland is functioning well, his cortisol should be high. And reverse T3 also high, but his free T3 might be low, and TSH might be normal or low. This sort of patient, better not to hurry to give a diagnosis. Actually, we'll wait and see. Better not to start treatment if you're not thinking obvious thyroid disease, and be mindful when interpretation. And right, if you can start, or you can actually, when you are doing thyroid function test in the very ill patient, better to think twice. We are going to expect some thyroid disease for this clinical presentation. Otherwise, better not to. Will wait. Then you can do better to the patient and to the government also. Right? Thyroid dysfunction in elderly, that is another entity, because we can't pick up this group of patients might tell out of hundreds of complaints in the ward round actually. But sometimes they may be having undiagnosed hypothyroidism for a long time, as I told earlier, because their thyroid reserve is not well, because they might have obvious hypothyroidism, because they might have elevated TSH if you have done those things. And because usually this elderly group, more than 10% of women and old more than 65, they might have thyroid disease, anyway, most of the time underactivity, hypothyroidism. Usually the thyroid dysfunction, I have told you already, they might have a lot of entities. There's a myriads of symptoms, asymptomatic to atypical manner. Sometimes deviation of blood, usually sometimes symptoms and blood test may be deviate in the elderly. Usually, even with the usually depression and apathy patient might show high suppressed TSH. We are thinking according to that patient should be hypothyroidism, but the TSH is very low. It can happen in elderly actually. In that case, we might tend to go for some repeat evaluation again, because patient is showing hypothyroidism symptoms, but TSH may be low, right? And there are a lot of non-specific neurological symptoms, musculoskeletal system, and a lot of somatic complaints, and they might have a lot of unusual investigation. All may be behind the thyroid dysfunction, maybe they are most probably. In that case, think twice. More than 65, that's why some colleges are telling that above 70, 65 years, annually screen is okay, but in our setup might be difficult, right? This is another important entity, pregnancy and thyroid function. We are much not dealing, but we might see pre-pregnancy patients in our clinic with the metabolic syndrome nowadays, no, right? In that case, if he's having metabolic syndrome, usually better to do thyroid function, then pre-pregnancy counseling and better planning we can do actually. And these are the pregnancy related usually. Hyperthyroidism, usually pregnancy can cause mainly the fetal and maternal impact, usually preeclampsia, stillbirth, and fetal growth retardation. And hypothyroidism also mainly can cause the detrimental effect to the fetus, usually intellectual deficit and growth retardation and miscarriages. Usually our management cutoff and their management cutoff is different. We have to be aware of that one, because first trimester you have to keep their TSH less than 2.5. Second and third trimester less than 3. Our cutoff is 4. No? We are product different. Right? Am I correct, Dr. Galan? Right. Another thing is pregnancy and thyroid dysfunction. Usually, this may be a physiological phenomenon actually. Usually, you have learned that HCG might act as a TSH mimicker, and it will stimulate the thyroid. Then usual thing is usually with the pregnancy initial half, their thyroxine requirement and the production might go usually 50%. Some might go over that one. They might present with the gestational transient thyrotoxic. This is a normal physiological phenomena, but without overactive. And they might present with some symptoms of hyperemesis. Usually we might encounter this patient in the medical world. If he's having a hyperemesis, better to do TSH, repeated admissions. And but this patient, we are not going to start definitive treatment. You can go for some symptomatic treatment, beta blockers. And other thing is, it is anyone who's on thyroxine replacement while she are getting pregnant in the initial phase, if we detected she's going to be pregnant, better to increase his thyroxine dose nearly 20 to 30% from the baseline, from the first visit. Better not to wait, because she's on replacement, but we have to go for minimum 20 to 20. Better to go for 30. It's no harm, no, right? Better to go for 30 straight away, right? Because absorption factors, because she's taking other things. She's taking iron, she's taking calcium. Better to go for, in that case, 30, right? Right. Other thing is thyroid emergency. There are large two main emergencies are there: myxedema, coma, thyrotoxic crisis. Better to manage in the ICU setup for HDU care. But these two most probably we are encountering the ward. Usually they are toxic with this medical emergencies. They may be having resistant arrhythmias, heart failure recurrent presentation, and maybe cardiac tamponade due to pericardial effusion with a severe hypothyroidism. These are medical emergency actually for us, but the pathology behind is the severe untreated hypothyroidism. And the thing is, I want to tell that usually when we are treating tachyarrhythmias with the beta blockers sometimes, but when we are treating with digoxin for some patient with the SVT, with the hyperthyroidism, we have to go for large dose of digoxin. They might not respond to digoxin actually because it metabolizes quickly with this hyperactivity. In that case, they might not settle with the single dose of digoxin for the bolus. And other thing is, when we are treating hypothyroidism, which have underlying adrenal crisis, we don't know that is the patient we are dealing with the ward sometimes. When we are starting thyroid replacement, they might go into crisis. That is also a crisis for us actually, because we can't imagine what happened to the patient is going to hypotension and she might go into shock quickly. Right. This is lowest entity, that is the hypothyroidism entity, the myxedema coma. Actually, it's a coma means patient is a confusional state is cloudy, and they might get seizure with the hyponatremia and other reasons. And they may be having a lot of metabolic derangement with this illness. They might have delayed tendon reflexes, hypotension, hypothermia. Most of the time, myxedema patients we observe they are obese. They may be having some respiratory failure. Usually they might cause undiagnosed long-term hypoxemia due to CO2 retention. That is central hypoapnea most probably, right? And they might cause signs-wise, they might hypotension, pericardial collection, hyponatremia, edema. Those things are right. Common things you can learn from whatever the books, right? Myxedema coma, actually, we have to treat differently because we have to go for very rapid correction of thyroxine. Usually we have to, ideally better to go for IV, but we don't have IV preparation. I don't actually, anesthetic team, we are giving orally. In that case, we have to go for frequent large dose NG. If this patient is cloudy conscious, better to go for NG. And maintenance dose, we can go back to that our previous known regime. Right. And other thing is T3 also we are not replacing, we are not practicing actually much here. And hydrocortisone we are giving because we are keeping in mind, we are thinking that maybe having some adrenal insufficiency. That's why we are already loaded with hydrocortisone, and you can start large dose of thyroxine. Right. This is actually straight away taken from the web. Actually, in that case, I didn't go through much. Here, actually, issue is thyroid storm is overactivity of the thyroid gland. Here, we are treatment is actually PTU. This is the first choice because it has peripheral conversion. Also, they can stop. Even other thing is that they can reduce the secretion also. And other thing is carbimazole. We are starting carbimazole here, but we have to go for a bit of frequent dosing in this condition. And other thing is iodine also might play a role in thyroid storm patients. Right. This is actually might present like a pheochromocytoma, like sometimes patient is very sweaty, clammy, tachycardia, and hypertension. All the things may be there in this patient, mainly the cardiovascular system, GI system, and CNS. Maybe confusion, delirious patient. Most probably the outer appearance might give sometimes clue, and previous records we have to go through quickly. And if patient suddenly stop his carbimazole, they might present it like this. In that case, we have to keep eye on thyroid storm. This is a life-threatening condition because they are very unstable cardiovascular wise. A little bit of thyroiditis because this is a commonest cause for. I wanted to touch all the things, but you can read all the things later with this slideshow. Right, thyroid. This is the commonest cause of hypothyroidism causes Hashimoto thyroiditis, and we can diagnose, as I said earlier, with the TPO antibody. Right, most common in the female, and the thing is, initially, most of the time they will present to us as hypothyroidism, not hyper, because we might detect them as hypothyroidism because thyroiditis, I told, with the destruction of the thyroid gland, with the sudden release of thyroxine, this patient most probably might present with the hypothyroidism presentation. Right. Subacute thyroiditis. This is another entity actually. This sort of patient might present with the tender thyroid gland with the very short history of recent viral infection, cough, upper respiratory infection. They might present with the thyroid tenderness, this area. We might attribute to some sore throat or something, tonsillitis or something, but they might present with this thyroiditis episode and fever, neck pain. And this patient we can diagnose. If he's having obvious tender thyroid, we can assess with the ESR, TSH, and T4. And if he's having some goit or something, we can go for radioactive iodine uptake assessment. Because this patient, this is a destructive thing. In that case, they might present like hyperthyroidism with the sudden surge of thyroid T4 level. Later, they might go into hypothyroid. But this patient, even they present with hyperthyroidism with the acute phase, if you are thinking he's having thyroiditis, better not to start carbimazole. This patient we have to treat it symptomatically. For the beta blocker, there's a place, NSAID, there's a place, steroid, there's a place, and aspirin also sometimes might. All are anti-inflammatory with the some symptomatic management with the beta blocker. Right. The thing is, we are not diagnosing, but we have seen few cases actually. This is a lymphocytic thyroiditis. This is a silent, as named earlier. Because this might present in the postpartum period, because these sort of patient can go undiagnosed, because postpartum is a very different, because we are more worried about the child, we forgot mother, but she might slowly go into the hypothyroidism with the depression, all the things we might attribute to postpartum psychotic diseases and other things. And the thing is, this patient might go into lifelong hypothyroidism sometimes. In that case, we have to look into postpartum in psychotic presentation and apathy and those things. Better to do thyroid function. You might miss this. Evaluating of thyroid nodule. This is a very usually more than 1 centimeter. This is all the things I already told you. Because all the palpable thyroid nodules are not malignancy. In that case, no need to worry. 95% is benign actually. But with the elderly patient comes with the thyroid nodule, be careful. They might be a malignancy. In that case, the elderly patient better to go for some scan and thyroid assessment, some further evaluation. And usually, if they are telling that if TSH is suppressed, there's a less likely of malignancy. When we are evaluating biochemically for the thyroid nodule, if patient with TSH is suppressed, they are telling that this malignancy is bit unlikely. But we can't tell 100% sometimes, right? Right. Thyroid malignancy, there are differentiated two types. Papillary, that is the commonest one. This right. This is a bimodal distribution with the age, extremities of age, and metastatic through the lymph, and most of the time we'll found with the METs and with the thyroid nodule. Follicular, this is another differentiated. Both they will release calcitonin. In the treatment, we can monitor with the calcitonin, the efficacy, right? Right. That is I told that rarely it causes thyrotoxicosis. Follicular carcinoma, they might cause thyrotoxic presentation. Not much high, but there may be suppressed TSH. This is a hematological spread with the bone mets lung involvement, right? This is a very destructive one, anaplastic carcinoma, very local invasion, and end stage they might come across us. And definitive is the surgery, right? Very low survival rate. Medullary carcinoma. This is the malignancy actually associated with the neuroendocrine tumor, and right, this patient actually presentation, even they can also go into the metastasis. They might present with the nodule. Unusual thing is this is some clinical manifestation relevant to the medical, because this patient might present with some diarrheal episode. They might have frequent diarrheal episode before malignancy presentation. And some features of Cushing's, because calcitonin play a role in these presentations, right? If he's having medullary carcinoma, if you diagnose, better to go for some family screening and those things, because they might get, because associated in the multiple endocrine neoplasia with the genetic. Right. Management, actually surgery is the first choice, and after that, if it's residual remnant, we can treat with the radioactive iodine, and you can monitor with the calcitonin, and you have to reassess with the repeat scan whether it's getting again. Right. These are the just I want to go for the summary, right? But the take-home message to actually thyroid dysfunction, most of the time we are over-treating, or sometimes we are under-treating. In that case, we have to rationalize our treatment option and investigations, and better to minimize the patient burden, because we are repeating next 3 months again we'll do thyroid function, and another 3 months we are doing that, because next time different doctor might see the patient, he might get a different then he will order again, and the health sector also getting burdened in doing repeated investigations. Okay, right. Thank you very much. Right.